Good morning, everyone. Happy Thursday. It's not any other Thursday here in the United States. It's Thanksgiving Day, which is, well, I should say, um, this is a global community of people. And I think when faced with options of celebrating every day or realizing that there are so many days to celebrate globally that you can't just keep it up, I'm, I speak I imagine I speak for everybody that we're very wary about hyper celebrating some days and not celebrating other days. Um, and so I say that with a little bit of caution to celebrate Thanksgiving, but it's hard not to be bathed in the environment that you're physically in, which I am, of course. But also the very spirit of Thanksgiving is something that I think resonates very well with this community is beyond the details of the story behind Thanksgiving, so on and so forth. I think what it means to people who live in the moment and maybe don't even know the story and legacy of Thanksgiving. It's really just all about being grateful, but especially grateful for the things immediately around you, often your family or the things that you've been blessed with. And so I find it perfect that I get to wish all of you happy Thanksgiving because whether you know it or not, I am very, very grateful for this community. Even those of you whose name I've never heard or who don't know anything beyond me, beyond the extreme nerdiness of doing these Thursday VMRs. I'm just so grateful that all of you have this shared common interest, both in learning and taking care of patients, but also in doing so with kindness and curiosity. So happy Thanksgiving to all of you in the spirit of the sense, even though the day may be of no practical significance to all of you. And I find it perfect that I get to celebrate Thanksgiving with Anmol, who is our case discussant today. But before I hand the mic to her to say hello, I want to thank three people. The first is Julia, who's doing the scribing today. Julia, say hello, please.
Happy Thanksgiving to everybody. I love, I'm just so touched by your kind introduction again. And I, I'm always like, you see, words are missing because even with this habit pretty much of case discussions each and every day, you always find some wisdom and very, very kind words that make me think like the whole day. And I really, really appreciate that. So you're definitely family, guys. Thank you so much.
Thank you, Julia, for the kind words. Guys, I want you all to guess who's doing teaching points today. Or shall we call them pearls, Elena? Yes, in fact, they are Parisa's pearls. Parisa, what's up?
Hello, everyone. Happy Thanksgiving. I'm usually speechless by Rabih's comment, and today's is one of those. I'm so grateful to be part of this community, and it's the best way to celebrate together. Let's discuss another case. So excited for your discussion, Anmol.
Hey, I want to give a big, big, big shout out to you, Parisa, for all the hard work that you're doing, and I hope you're inspiring many of our junior academy members to see what it's like to jump in and really put yourself out there. And the skill set that you're developed is so obvious. Um, so really kudos to you for all the hard work you're doing. I want to give a big shout out to Francisco, but I have news for him because I think he can sit back and relax. Um, but I'll explain why in a second. But a huge, huge shout out to Francisco, who I actually would love to hear from an update for everybody since we haven't heard from Francisco in a long time. So, Francisco, what's new with you?
Hey everyone. Yeah, intern year currently going well. Going for Christmas pretty soon back home.
Yeah.
And yeah, I know I'm grateful for this community. Not the most active member, but you're always on my heart. I'm always thinking about you guys and a lot of friends here, and it's always a pleasure to be back. Yeah.
I saw Francisco's name on my radar screen pop up when we were doing an academy session later today for the academy members, and as soon as I said the word EKG, I saw Francisco's name pop up immediately, which was really, really cool. And by the way, you don't have to be you don't have to caveat the most active member. I think it's impossible to be active at all as an intern, but we really, really appreciate you being here, especially on Thanksgiving. I'm really sorry about the football slash soccer news from Portugal. I know that probably really, really I can see the sadness still on
Are
your
you
face.
happy, Ravi?
Um, I don't know.
Can you coach?
I'm cautiously optimistic. I don't know if I want to be happy and have my heart broken, but we'll spare all of you guys the details. The reason I wanted to shout out Francisco in particular is he had jumped in to present a backup case, but we're very, very lucky. I see our current case presenter actually joined the session. Hi, Sadika. Nice to meet you. Thank you so much for joining.
Hi, good morning, Dr. Rabih. Thank
Good
you for having me.
morning. Absolutely. It's an absolute pleasure. Tell us a little bit about yourself if you don't mind.
So I'm a doctor from India, and I'm going through what's been an excruciatingly long math cycle. I've applied to internal medicine, so going through that. Yeah.
Where are you located now?
I'm in Hyderabad right now in
In
India.
Hyderabad. Amazing. Awesome. Yeah, we've had many a presenter from Hyderabad. Welcome. How was your journey to medicine? What was that like?
My journey to medicine was a bit, I think, unconventional. I
Mm.
was on track to pursue journalism initially, but then I made a
Ah,
pivot to medicine, and because of a personal health crisis that I went through. So it's been somewhat unconventional.
yeah, well, I would say you've turned something that sounds really, really rough into something that's so cool and so powerful, which is wonderful. How did you find this community? How did you hear about CP Solver?
I've been following CPS Solver for quite some time now. I think passively. I haven't joined the sessions live, but I've been following them on YouTube for some time now.
Amazing. I
Happy
hope
to
you
be
get to
here.
watch yourself present at some point on YouTube. It's going to be out there. Very, very grateful that you're showing up here and sharing us the story. This is a patient that you saw in what part of your training?
I saw it during my clinical rotations recently in the US.
Amazing.
So
Oh, in the US. Okay, gotcha. Where did you spend your time in the US?
I spend my time on the East Coast, mostly in Baltimore and New Jersey. So
Amazing. All right, we have a lot of Baltimore representation here. Well, thank you so much for joining. We're very excited to get to know you even better as the case goes through. I just want to hand the mic to Anmol to say hello and thank her for discussing our third case together, I believe. But I'll hand the mic to you, Anmol, to say hi, and then we can jump into the case.
Yeah. Hello, everyone. Excited to be here on Thanksgiving. And I'm always thankful to CP Solvers and all the members. And definitely even if I don't express it, CP Solvers always brings a smile on my face. Even if the whole day went bad, CP Solvers 1 hour, I'll be smiling. And then at the end of the hour, my face is glowing. So thank you very much. And excited for today's case.
The feeling is mutual, Anmol. You bring a lot of joy to a lot of people here. We're very, very grateful for you. All right, guys, you ready to rock and roll? So, Julia, whenever you can, we'll go ahead and share the screen and we'll hear Sadika's case. All right, so I think we're ready whenever you are.
all right. So this is a case of a 60-year-old gentleman who presented to us in the ED with 5 days of knee pains, swelling, and inability to ambulate, with a 5-day history of that. And he endorsed subjective fevers and chills. He'd previously been seen in another ED 3 days prior to this presentation, but was treated for a gout flare-up, for a suspected gout flare-up, and discharged on NSAIDs. And he now presented in this admission with worsening symptoms. And he denies trauma to the knee.
I hope this is where you want us to stop. I'm sensing that based on your thoughts on it. Is that right? Because it's such a great place to reflect. Is that okay with you?
Yeah, thank you.
Perfect, perfect. Anmol, it's shocking to me that there are very few instances where we can get to discuss joint issues on VMR. So I'm very, very excited for this. I'm really just curious to tap into your thoughts so far. What is flowing through your mind?
Yes, it's a very interesting aliquot, and we can learn a lot from this unusual complaint on the VMR. But whenever I think about a joint pain, the first thought that comes to my mind, if I can classify it into 2 buckets, or 3 buckets mainly: monoarthritis, oligoarthritis, and polyarthritis. That I say because if it's a singular joint involvement, then there is a high chance of the surrounding structures involvement more than the bone involvement, like the ligaments, the capsule, the other structures which can be involved in a singular joint involvement. And if the other joints are involved, then we can think about the other bony disorders which we can think about. And if if I see this patient is having acute onset knee pain and no previous episode, uh, monoarthritis, fevers and chills, then definitely septic arthritis also comes to my mind. That's just one of the differential, and that's what I'm thinking right now.
I think it's amazing how much you were able to say in such little words. And I think you're absolutely right. If a patient reports one area is bothering them, that suggests a monoarthritis. But you said you made a really important caveat, which is you said when a patient complains of one joint, it's actually more probable that they have a peri-articular issue, like a ligamentous or bursa issue, than an actual intra-articular issue. That's in stark contrast to when patients say they have multiple joints involved, because multiple simultaneous bursal issues or ligamentous issues are much less common than a multiple intra-articular issue. So I think if you were to distill down what you said and repeat it just to emphasize it, it's that when somebody says their joint hurts, they don't have the ability to distinguish between an issue around the joint, like a bursa, or an issue in the joint. One easy clue, short of the definitive way to tell, which is the physical exam, is to listen to how many discomforts they have. If it's just one area, it's likely to be a periarticular issue like rotator cuff disease, which has nothing to do with the shoulder joint. But if it's multiple joints, it'd be much more common to be intra-articular. So here, you're dealing with one joint, and so you're much more likely to be worried about a periarticular issue in general. So are you still, Anmol, in the world of periarticular disease, or are there additional features of this case that are making you worry about an intra-articular disease, even though it's less common when it's just one joint?
I think that with the subjective associated fever and chills, they make me think if the joint is involved. Um, or maybe it can be an evidence of inflammatory features. Maybe it's just the initially we just can't say if initially it's a joint problem. It could be a problem in the whole body. Fever can be anything. So, but if I think about right now, I think we will focus more on the joint.
Yes.
In this case.
Agreed. The vast majority of periarticular diseases are gentle. And when somebody is having a systemic response to a joint complaint, the probability that that complaint is deep, i.e. in the joint, increases. However, you can still get inflammatory diseases of the periarticular structures. So for example, you can have septic bursitis as a way you can have knee pain and swelling. And cause systemic symptoms. But I would say that most of the time when somebody's shoulder hurts or knee hurts, there is no systemic response. And the presence of a systemic response really mandates the evaluation for a deeper structure. So, Anmol, you mentioned now that you're thinking about a joint. If we were to prepare for a joint problem, which we'll have to wait to really commit to upon exam, what kinds of information do you think will help you in the medical history or even the HPI to understand what the cause of the joint problem might be?
Yes, I think an important history to be elicited from the patient would be any history of trauma to the joint.
Excellent.
And we can also know if of any past medical history, as the patient, as the aliquot says, gout flare. So if any past history of gout is present or any other past medical history is present, which we can maybe understand from the medications as well. So that's what I'm thinking.
Excellent. Superb. Yeah, there are two, but we all hold our breath until we rule out infections as the cause of joint pain. And one thing that helps us make progress towards a non-infectious cause is the presence of risk factors or diagnoses of the main non-infectious consideration, which is crystalline disease. So that helps. The other thing that causes us to prioritize non-infectious causes is the lack of portal of entry for infection. And the two portals of entry are the skin through trauma, but it's actually much more common that the portal of entry is through hematogenous dissemination. And so risk factors for bacteremia are huge in this circumstance. So if we learn that he has anything wrong with his blood vessels, either because he injects in them, or he has an AV fistula from dialysis, or has a prosthetic valve, or has an ICD in place with prosthetic material, the calculus for this patient will change dramatically. And so I think what we're saying, to summarize, Anmol, is even though this is one joint, which would ordinarily prioritize a periarticular issue, he has one of the two red flags: inflammation or instability. We don't know if he has instability, but he has inflammation. That is pushing us to prioritize an intra-articular issue, which for a monoarticular disease is either crystal or infection. Crystals are much more common than infections, but infections are much more deadly. And so the key thing to try to see is, do we get more momentum for crystal by history, or more momentum for infection by often an endovascular risk factor? So let's see what Sadika has in store with us in terms of that information.
All right, so the review of systems was unremarkable, except for the presence of pain in his right knee and his past medical history. He has a history of a previous admission for left wrist abscess 4 months prior to this admission, which was treated with decompression, incision, and drainage. And inpatient, he was treated with Unison and vancomycin and discharged on linezolid and augmentin, a 14-day course of that. And he also has a past medical history of gout, osteoarthritis of both his knee joints, and he also endorses a history of polysubstance use and asthma. Sorry. His medication history, he takes Symbicort and albuterol as needed, and he was discharged by the previous ED with ibuprofen. His family history is unremarkable. As for his social history, he is unmarried and lives with his family. And he has a 1 pack per week smoking history with alcohol use around 5 standard drinks per week. And he shares a history of marijuana and crack cocaine use. And he's been sexually inactive for the past 3 years. He denies any travel history.
All right, we've given us a lot of intriguing information. Anmol, what did you find relevant in the past medical history that influences your thinking?
I think we were talking about if we are prioritizing infection in this case, which we first should, since it is a more emergency condition than a crystalline flare. If we are prioritizing that, then if the patient is having IV needle abuse, drug abuse, then we have a source of bacteremia in this case. But the involvement of other joint in the form of abscess is also interesting to me. And I think these are the main 2 points which I thought is important. The abscess formation, that is a previous that was the infection of the joint, like 4 months prior. So this time also it raises the concerns of an infection in the knee. That's what I'm thinking.
Absolutely superb. I love that you ignored the history of gout, because I did too, because it doesn't matter. This patient has too many risk factors for infection. And I think that your observation about the left wrist abscess, even before you had the polysubstance use disorder, is really, really powerful. And I say that because developing an infection on the upper extremity is exceedingly rare without trauma. Anmol, you'll see in the ER that you're working cellulitis of the lower legs all the time. However, an infection of the upper extremity is almost always either due to prior lymphadenectomy for various reasons, breast cancer, so on and so forth, or a bite or an injection. And of course, a bite can happen from a pet. An injection can happen from the hospital. But I think when you see a spontaneous wrist abscess like that, you really have to worry about a needle in that area. And I say that because we don't quite know yet how he uses cocaine, or if in fact the use of these substances is through injection. But I think that the very nature of substance use disorder involves minimizing to oneself and others the severity of the problem, which requires us to be thoughtful of the burden that the patient bears in their difficulties articulating the nature of the use and how often they use, in large part due to social stigma, and also just the very nature of the disease itself, which from a distance makes one dishonest with oneself. And so even if we learn that the patient does not report himself using any needles, the presence of a spontaneous wrist abscess would have us open to that possibility no matter what. So as we move to the next step, Anmol, I think that we're definitely going to get a knee exam. I'm just curious if there are other parts of the exam that you are actively going to perform with more attention than the typical maneuvers that you do. So what part of the exam, in addition to the knee, are you particularly interested in?
I think to examine all the joints will be important rather than just one singular knee. And then we can check for some, if we are suspecting bacteremia, if we still don't know if he's an IV drug abuser, we can examine the spine to see any point tenderness there, or to just see any other signs of bacteremia, which we can see. Any skin examination would be important to look for any rash. I think point tenderness in spine, and that's what I'm thinking.
You're absolutely right. I think the first thing you said is we want to know what the problem representation is. Is this monoarticular or polyarticular? And then you reminded yourself that monoarticular or polyarticular is usually endovascular infection. So could this patient have other sites of infection? Unfortunately, the most common site of infection is an endocarditis. And so as you being the endocarditis queen, having presented many cases now, including endocarditis, I think that the presence or absence of spine tenderness, skin rash, and a murmur are all going to be really important to help us figure out if this patient has an endovascular infection. So that's really, really astute observation on your end. Now, why don't we get the exam, Sadika?
Right. So his physical exam was unremarkable, except for the presence of swelling, warmth, and tenderness in his right knee. And the swelling extended above the right knee, and a healed scab was noted below the joint. As for his other examination findings, we found some discoloration, blackish discoloration of some of his toenails. And apart from that, his physical examination was unremarkable. His vital signs were his temperature was 98. Heart rate was 98 per minute. His blood pressure was 130/70. His respiratory rate was 20. And his SATs were 99% on room air. His initial labs were, his initial labs, his RBC count was 4.29 million per millimeter cube. WBC count was 7.71. Hemoglobin was 13.4. His platelet count was 269,000. His sodium was 137, potassium 3.7, chloride 105. His blood sugar, random blood sugar was 130, creatinine 0.5, calcium 9.1, and his phosphate 2.3.
You're presenting this like a pro. Oh, that's awesome. Thank you so much for making us really feel the tension that you probably felt, and the humility that, hey, actually, he doesn't really have anything else except that knee. So Anmol, you got a lot of data. I'm really curious just to capture now what your one-line summary is. So if you were to help the team out and try to fill your problem representation, what would be your problem representation now?
Yes, my problem representation would be a 60-year-old male with past medical history of gout and left wrist abscess, presented to the ED with 5 days of knee pain along with fever and chills. And the patient also has polysubstance use disorder with normal vitals and sweating, warmth, and tenderness of the knee, normal labs, and black discoloration of toenails.
Amazing. Excellent. Yeah. Your problem representation is very precise, painting a picture very much so of the circumstances before you. And if you were to take your problem representation and ask yourself, what's the core fundamental problem? I think you're identifying it. You're identifying it as a patient with acute monoarticular arthritis with risk factors for septic arthritis. So if you were to distill it down even further to its bare bones, acute monoarticular arthritis with risk factors for septic arthritis. I'm curious, are you confident now that this is an arthritis, or are you open to this being a periarticular disease?
I think I would more concern more with intra-articular than periarticular, but I don't know if we have another teaching point about that. But
Yeah,
I think I would focus
oh no, I think we
more on
lost you.
intra-articular first,
Yeah.
and the presence of. Can you hear me?
Yeah, I think Anmol, your audio chopped out for a little bit, but we heard, yeah, you were just we were hearing you explain why you thought it was intra-articular, but I think it cut out. So you want to take a second stab at it?
I was just thinking about the
Yeah.
case I presented about infective endocarditis, which
Yes.
had septic emboli.
Yeah.
So I remember that patient had black discoloration on the fingers. I had seen that case myself. So just similar picture came in front of me that this patient has black discoloration of toenails, and if I would think about that. That probably this patient has a source of bacteremia which is affecting the joints and has embolization to the periphery skin. If we're just thinking about that, we're not pretty sure that the black discoloration of toenails means this, but I'm just thinking that intra-articular would be more important than periarticular in this case.
Definitely.
Yeah, that's what I'm thinking right now.
Absolutely superb. So I think that the focus on the exam with the fact that the patient has diffuse swelling of the knee is really suggestive of an intra-articular process. The things that would cause periarticular disease are prepatellar bursitis, where the swelling would be localized across the prepatellar bursa, or the patient would have instability. So the patient would have ACL or MCL tears, and you would be able to, the patient would have instability on exam. So the fact that the knee is diffusely swollen without instability is very, very suggestive of it's okay. It's all good. Sorry, I spilled my coffee all over the floor. So Anmol, for the rest of the discussion, I'm gonna need you because I don't have any coffee anymore. So I think we have to proceed with this being intra-articular. And I think, Anmol, you're seeing the classic story of intra-articular. And that is that there is nothing else going on anywhere else. So I'm really curious now, you were worried about septic arthritis. Has your concern for septic arthritis increased or decreased with the labs that we received?
The labs, the only abnormality I can see is the raised inflammatory markers.
Yeah.
So yes, but I'm surprised with the WBC count. I'm not sure that if they were meant to be raised. But with raised inflammatory markers, yes, I am still thinking about septic arthritis because I know that septic arthritis is very, very dangerous, and an
Yes.
empiric treatment of antibiotics is necessary even before we do the tap or something.
Yeah. Anmol, you are not falling for my traps today. This is amazing. You're right. Septic arthritis is not a systemic inflammatory disease. In very, very severe forms, patients will have a white count, a high fever, so on and so forth. But septic arthritis, especially monoarticular, just presents like this. There is no, it is a contained infection in the knee, just like an abscess. So just like a skin and soft tissue abscess, the patient has no fevers, no chills, no white count. And the way to make progress is to tap the knee. And yes, you're right. If you need some time to tap the knee, you should treat empirically. But it takes no more than 2 minutes to do a knee arthrocentesis. Very, very quick procedure. Clean with iodine chloroprep, needle right under the patella with lidocaine, of course, fluid out. That's it. So most of the time, because of the relative ease at which you can do an arthrocentesis, that is the key step. So we will discuss more about the value of arthrocentesis, but I wanted to ask you, if you and I are taking care of this patient in the emergency room, which one day, if that's true, my dreams will come true, we're going to get the arthrocentesis. I'm going to show you how to do it, and then you'll do it, and we'll be very happy thereafter. But there is some other testing we should get while we are getting the arthrocentesis. We're going to ask the nurse to help us get some other things. So what other things diagnostically do you think are important in this case?
Thank you for sharing your dream, Dr. Rabih. I think now I'm forgetting what I have to say. Yes, I think the tap will be important. We have to send the cultures from that as well. But other than that, I think I don't know. Maybe if you're asking for any imaging or something, maybe we can maybe before giving the antibiotics, we can get send the blood cultures.
Yes.
And
1 out of 2. There's one more test.
And if imaging, then I would say a POCUS echo. We can do a POCUS echo if it's accessible in the ED.
Yeah, you can. The role of imaging there is no role of imaging in the diagnosis of septic arthritis because the stakes are too high, except bedside ultrasound. The only role for a bedside ultrasound is to confirm you have that a patient has fluid in the knee. So a POCUS can help you confirm. Also, a POCUS can help you see if there are loculations in and around the knee. So if a patient injects right in the knee and gets septic arthritis, they may have, in addition to a septic arthritis, may have myositis or periarthritis. So there might be abscesses there that you don't appreciate. But what's the core teaching here, Anmol? The core teaching here is, number 1, do not set septic arthritis aside if the patient does not have a systemic inflammatory response. Most people don't. So do not be surprised by the normal white count here. It is the norm. If you happen to have a patient who has a systemic response, that prioritizes septic arthritis, but the lack of it does not exclude it. That's learning point number 1. The arthrocentesis is the single most helpful test to understand what's happening in a joint. And it's no surprise that you've sampled the fluid and that tells you what's going on. 25% of patients with monoarticular septic arthritis have bacteremia, so the value of blood cultures is enormous. There is almost no role for imaging in the diagnosis of septic arthritis because the arthrocentesis is the main step, except a point of care ultrasound to help you verify fluid. The point of care ultrasound is more valuable in smaller joints like the wrists or the MCPs where you cannot really tell for sure. The other key test to always consider is a mucosal swab of the mouth and genital region for gonorrhea. Even if the patient reports that they are not sexually active, you have to consider the possibility of disseminated gonococcal infection, especially because the only place you will reliably find it is the mucosal surface. In disseminated gonococcal infection, the yield of the arthrocentesis for culture is low and the blood cultures are low. So we have to think about whether the patient has DGI, disseminated gonococcal infection, bacteremia, and use POCUS to help us make sure there isn't an abscess in the soft tissue around the knee or in the bone, like contiguous osteomyelitis. But the knee tap will be very, very, very informative here. Okay. All righty. Radhika, what do you have in store for us?
All right, something I forgot in the previous aliquot was the ESR and CRP. So I'll just mention that before moving on to the fourth aliquot. The ESR was 56 and the CRP was greater than 12. And moving on to the fourth aliquot, a synovial fluid analysis was done in the ED. And we found that the fluid was frankly cloudy. And the WBC count was more than 100,000. With 90% polymorph nuclear leukocytes, and the RBC count was more than 20,000. No crystals were noted, and the arthrocentesis was also negative on gram stain. The patient was then okay. Yeah, I'll stop there.
No, thank you for stopping. This is perfect. I can really tell that you have a great command of this case because of where you're choosing to stop and what your learning points probably were. So thank you so much. I really appreciate it. So, Anmol, everything is negative. There are no crystals, there's no gram stain. So when shall we discharge the patient? What time?
We should definitely empirically treat with antibiotics.
Yes. No traps you will fall into. So what are before we dissect this case, I forgot to talk about in the last aliquot. We said you wanted to treat empirically. What would you consider giving this patient as empiric treatment?
Maybe ceftriaxone, vancomycin.
That is the standard of care for septic arthritis in the United States, is to give vancomycin and ceftriaxone. The vancomycin is for staph and strep. The ceftriaxone is for two reasons: disseminated gonococcal infection and gram-negative rod infections, for sure. So now that you've done that, now we can sit, relax, and think. So what do you think about this arthrocentesis?
It definitely has. It looks like with raised WBC, it looks like infectious septic arthritis. But one thing I recall about testing about chlamydia and gonorrhea from septic arthritis is that some of the tests which we send has high sensitivity and specificity, and sometimes arthrocentesis cannot reveal those organisms. I don't remember what tests we send for that, but I believe that there is a certain test which we send to confirm disseminated gonococcal infection. Maybe we need to send another test. I'm not sure which one.
Yeah, you're 100% right. So the difficulty in diagnosing disseminated gonococcal infection is very well described. The good news is the most high yield test is swabbing the origin of the bacteria wherever it started. So I would recommend in a patient, and everybody really, to swab the mouth, any mucosal surface, the mouth and the genital area. So I think that is really, really key. In terms of getting the diagnosis of septic arthritis, I think this is a really important conversation for us to have. So Anmol, I'm going to share with you a schema that illustrates this principle, because this is a very, very difficult thing. For those of you who are interested, these schemas, these are kind of extra schemas that we have that you can find on rlrcpsolvers.com. You won't be able to find it on our regular website. So, Anmol, here is what we're going to do. The first thing is we have to decide, is it inflammatory or not? And whenever it's over 2,000, it's inflammatory. If we get a positive gram stain, Finished. No more thinking left to do. It's septic arthritis. Anmol, do you know what percentage of patients have a positive gram stain in septic arthritis? Rough guess. Let's see how your lottery chances are today.
I think 40 to 60%.
50%, 100% right. Nice job. You should totally, today's your lucky day. So if the gram stain is negative, you ask, what are the crystals? If the crystals are negative, finding crystals for crystalline arthropathy is extremely sensitive. The lack of crystals is very, very suggestive that there is no crystalline disease. The lack of a gram stain is not at all sufficient to exclude an infection. So if you have two negative tests, which one is a good one to trust? The crystals. So here, I don't trust the negative gram stain. I trust the negative crystals. The small caveat is in calcium pyrophosphate disease, CPPD, otherwise known as pseudogout, there is an appreciable level of false negativity, but that doesn't matter in the acute moment. So we're here, we're in a gram stain negative, crystal negative. This is septic until proven otherwise. As you said, how do we prove otherwise? We prove otherwise with swabbing every mucosal surface, with waiting for the blood cultures, 25% chance of being positive. Anmol, do you have any guess what the culture of the synovial fluid is? How helpful that, how often that's positive?
I think culture of synovial fluid is, we should get that. I think, I'm not sure about the percentage, but
Take a guess. You were so right earlier. Well, take another guess. What do you think?
I think 70%.
Oh my God, this is scary. You're exactly right, 70%. So Anmol, think about it. There's a 30% chance we find nothing, no bugs anywhere. And this is a real life dilemma. So this is how we try to approach that dilemma. Again, gram stain positive, treat the patient. Gram stain negative, crystals negative, treat the patient. How long do we treat the patient for? If you have no other explanation, you will complete a full course of empiric treatment because you have no other explanation in this high-risk person. If you find a microbiological cause, then you can tailor your antibiotics accordingly. I do not see a pathway out of antibiotics for the full course for this patient, with the only question left: are we going to be lucky enough to have a microbiological cause? In 7 out of 10 times, we can tailor the treatment for septic arthritis. In 3 out of 10 times, the patient completes an empiric treatment. So I'm curious if you have any thoughts or any questions about that or any points of clarification.
No, I think it's a great case. I will have definitely a lot of learning. Maybe, and I would definitely want to share that I've been listening to VMRs for over an year now, and all the knowledge, I can recall 3-4 VMRs, I think, which I'm trying to recall what was that, and trying to take some of the teaching points. So from that only, I remember there are some tests which we send, which are more sensitive and specific for this joint testing. But it's a really great case. Thank you for bringing it up. And I'm excited to see what next tests were done and what the results show.
Exactly right. I'm right there with you. And I just want to emphasize, don't be underwhelmed by the lack of systemic inflammation in septic arthritis. Look how inflamed this joint is with a normal white count. And don't stop antibiotics because the microbiology is negative. Even culture has only a 70% sensitivity. Alrighty, Sanika. Wow, what an incredible journey you've taken us so far. What's the next phase of this case?
I feel like the Hercule Poirot with the final reveal. So before the final reveal, I think I'll just mention some stuff that I forgot to add. As for imaging, we did do an X-ray of both his knee joints. The changes were consistent with osteoarthritis, but it was otherwise unremarkable for any acute abnormalities. We also did a 2D echo, which was unremarkable. And the patient was then planned for an incision drainage the next day and was started, like Dr. Rabih mentioned, vancomycin and ceftriaxone. But I think the team wanted to start the patient on cefazolin and ceftriaxone instead, and the patient was sent in for the procedure. Intra-procedurally, the patient was given tobramycin and vancomycin, and there's a note, an intraoperative note that says that the fluid was frankly purulent, and cultures of blood and synovial fluid were sent and ID team was also consulted. Post procedure, the patient was switched to ceftriaxone and vancomycin because the ID thought that the patient was relatively high risk for MRSA, and his STI panel, HIV, Hep B, HCV were all negative, and the blood and synovial cultures were also negative initially. We also did a TB AGRA, which was negative.
Alrighty, wow. And Sadhguru knows how to make tension in the room. So Anmol, what are you thinking with this information?
I'm just thinking, why did Dr. Sadhika said initially? So if the
Amazing.
if
Well,
the
let's
culture
let's do the exercise. What do you think causes culture negative inflammatory arthritis? Just in general, culture negative inflammatory arthritis. What do you think?
I know that the most common cause for culture negative endocarditis is prior treatment with antibiotics.
Yes, excellent.
And, that I know from the case I presented, because I know that that case was also culture positive, but it was prior treated with antibiotics. So maybe that is the cause here. And
Yeah, 100%. If you're making a schema for culture negative inflammatory arthritis, the first thing that you would want to entertain is that the patient actually has a septic arthritis with inherently negative cultures. Septic arthritis is so hard to prove culture positivity. So as we mentioned earlier in the last talk, a 30% chance of having culture negativity. The chances of culture negativity are even higher in disseminated gonococcal infection, up to 50% culture negativity. But you have to step back and say, does the patient have something else? And the one crystalline disease that can actually be crystal negative is CPPD. And so in a 60-year-old man who has osteoarthritis in both knees, you might wonder, hey, does this patient actually have CPPD? And so you would never stop antibiotics because of the possibility of culture negative septic arthritis. But in some cases, patients are also given anti-inflammatory treatment in parallel to treating septic arthritis. So that is something that is done. So what happens with culture negative inflammatory is you doubt the negative crystals and you say, could it be CPD? And you doubt the negative culture, but the negative culture is not good enough to make progress. The major thing you have to ask yourself is the knee the actual focus of infection? Or does the patient have tibial or femoral osteomyelitis? And that's where the infection is. And the patient has an adjacent inflammatory effusion as a result of the osteomyelitis. This is a very common phenomenon in kids where they have osteomyelitis trigger an adjacent inflammatory effusion. So what would happen in a patient like this? You would empirically treat with broad spectrum antibiotics with vancomycin, ceftriaxone. You would entertain the possibility of treating for CPPD, especially if you review the knee films and you see evidence of chondrocalcinosis on the knee x-rays or the wrist x-rays that he's had in the past. And in parallel, if the patient does not improve with the serial drainage and arthrocentesis, then you would have to ask yourself, do I need to get an MRI of the knee and thigh to see if the patient has an abscess in the soft tissue or an abscess in bone, otherwise termed osteomyelitis. So 3 prongs to this schema. Is it culture negative septic arthritis? Is it crystalline disease with negative crystals? Or is it an adjacent infection with an inflammatory infusion? Any questions about that, Anmol?
No, it's amazing to think that medicine can be so complex when we think of septic arthritis without any with negative culture, crystalline disease with negative crystals, or an adjacent infection. That's amazing. I think it's
Great
great.
summary. All right, Tanika, the mic is yours.
All right. So at this point, I think when we were seeing the patient, we kind of, because of his atypical presentation, we kind of went back and did a chart review of his previous admission to see if he'd grown any organisms, and he hadn't. And at that point, he was, like I said before, he was treated with vancomycin unison inpatient and discharged on linezolid and Augmentin. Now he continued to have no growth except cons on the first 2 days, but on the 3rd day, and if I'm allowed to do a final sort of reveal now, on the 3rd day, it came back positive for Cutibacterium acne. So he was a case of Cutibacterium acne, septic arthritis.
It's the most inappropriately named bacteria because there's nothing cute about it. It causes such bad things. But have you heard about Cutibacterium, Anmol? I hope the answer is no. So finally, you can say no. Okay,
No.
finally. Maybe Sanika can teach us a little bit about Cutibacterium. What did you learn about it, Sanika?
I learned quite a few things about Cutibacterium acne, that it doesn't just cause acne, obviously. It causes a host of other conditions as well because it resides in the hair follicle unit. When you perform procedures, that kind of leads to seeding of some of the joints during implant placements, and it causes infections of those implants. So that's been fairly commonly reported. And something that that I'd never heard of before was sarcoidosis. So someone tested, I don't know who did that, how it occurred to them, but they decided to test the sarcoids and it came back positive for Cutibacterium acne. So this was something very new to me. And something else that I also found out about C. acnes was Sappho syndrome. So this is not something that's been studied or I think documented much, but that's also something that I learned about. So quite a bit of learning from C. acnes after this.
Absolutely superb. I'll just sprinkle my 2 cents, then get reflection from Anmol. Yeah, Cutibacterium acnes is a very, very interesting organism because the ability to distinguish pathogenic activity, meaning it's causing problems, versus incidental colonizer is very, very difficult. The most robust association clinically that we have with Cutibacterium acne is prosthetic joint infections. It is a gram-positive rod that is found in the skin, and so knowing whether it's causing disease or an incidentaloma is difficult. In a case where you don't find anything else, I think it's very easy to be suspicious of causality, as you might be in this case. But Anmol, I would love to hear your reflections on this case. What was it like to discuss it, and what are the things that you're taking away from this discussion?
Definitely, I'm taking away a lot. Every time I discuss or listen to a discussion of VMR, it enhances when I'm myself in the ER and I'm looking at the patient, then so many things come to my mind from the VMR. So definitely, I think I'm not very good at infectious disease. So this was really, really interesting to see how the patient was evaluated, how we were thinking that this patient could have a periarticular or intra-articular process, and then we focused on intra-articular septic arthritis, and we talked about the management that we need to focus on antibiotics first, and then we can make our diagnosis. And the reflections of not a high WBC count because of the contained infection. There's a lot to take from this case. Again, the same things, crystalline disease without the presence of crystals, CPPD, or culture negative septic arthritis. So there's a really lot to learn and wonderfully presented. Thank you so much for bringing up this case, and thank you for discussing it with me. Thank you.
Absolutely amazing discussion, Anmol. I think it's hard for us watching you to say your ID is weak when you know the rate of gram stain negativity and culture negativity and septic arthritis. But I appreciate your humility and your desire to learn and grow. I'm curious, Sadika, what was it like to take care of this patient? What were your main learning points along the way?
It was quite interesting, actually. I think some of the things that I kept from you guys through the presentation was also something that I was anchoring on when we saw the case. And the first time I saw the patient, this is something I discussed with Francisco and Mukund as well. The patient obviously had a complex social history. And as you said about this, about how honest the patient is about substance use, that was something that I was definitely thinking about. And I also saw that question in the chat about people asking about the route of administration of substance use. And I think we kept asking the patient, in fact, and he kept denying it. But there was that thought at the back of my mind that, he's probably not being very honest with me. So that was definitely one learning point that, you have to believe the patient when they tell you that. So that kind of anchored, I think, our own diagnosis towards Staph aureus, more likely a more common bug than something uncommon like Cutibacterium acne. And something that I think we did some more investigations and we found that he was positive for HLA-B27. So he was discharged later on. So it's an ongoing, I think, on follow-up, we find out more about him. But yeah, definitely an interesting case.
Absolutely. And I think your summary of the tension of is there an injection or not, I think has been ultimately it's a suspicion, and a suspicion that you should never cast judgment on the patient, but you should not miss out on the opportunity to deliver them high quality care by understanding that. So if you said, oh, there's no risk of Staph aureus here at all because the patient isn't injecting because they say so, I'm not going to give them back, that might be a setup for disaster. But at the end, your reflection is spot on. This organism is not consistent with injection drug use. And so you would be like, oh, okay, it didn't turn out to be in this case, which is very, very wise. I really, really hope we see you on VMR again. This was a really, really awesome case that I think really highlights the fundamentals of what we're trying to do. A lot of bread and butter conversations, one joint versus many joints, interarticular versus periarticular, differential diagnosis of septic arthritis. How do you interpret the negative tests? What are your empiric antibiotics? All those are things that you're going to live and breathe every single day in most care places, no matter where you work. So thank you for giving us the opportunity to do that. It's time though, guys. Oh yeah, for sure. Thank you. It's time for Parisa's Pearls. Parisa, what have you got?
Thank you, Sadika. It was a great case and wish you best in your match season. And Anmol, it was an amazing discussion. We started with a patient who came in with a knee pain. And we started to categorize the joint pain in the 3 different buckets as we do usually. We differentiated into monoarticular, oligoarthritis and polyarthritis. We know that when patient presenting with monoarticulaриtis, it's particularly the likelihood of having a periarticular issue is higher. If we want to discuss about the other clues we are having in the physical exam, when the patient, the joint is diffusely swollen, probably the likelihood of having intraarticular issue is higher. And when we are having instability in the joint, the probability of having ACL or MCL tear is higher, and we are having periarticular problem. And when we are having monoarticular monoarthritis, the reason for that is infection and crystalline diseases. When we learned that systemic response to joint complaint increase the risk of having intraarticular disease because we are having deep structure, but it's not ruling out that the situation that, for example, in septic bursitis, the patient might be febrile as well. We talk about the infectious risk factor for the patient, specifically the endovascular risk factor, meaning that the patient have a portal entry on their skin like trauma, or they might have hematogenous dissemination, like they might have injection, they might have AV fistula, they might have prosthetic valve, or they might have ICD valves. We learned that it is really rare to have upper extremity cellulitis versus lower extremity cellulitis. And when the patient is presenting with upper extremity cellulitis, they usually having prior lymphadenopathy, or they might have pet bites, or they are having injection, although they might not admit they have an injection, but it is raising the concern for needle injection. We learned that when somebody is presenting with these chief complaints, we need to examine them truly, and we need to go for the other resources for the endocarditis. For example, for instances, we need to look for a spine tenderness, we need to go for skin rashes, we need to listen for any kind of heart murmur. We learned that septic arthritis is not necessarily any systemic inflammatory disease, meaning that the absence of leukocytosis or fever, it's not ruling out septic arthritis, because septic arthritis is a contained infection. It is like an abscess. And then we usually tap the area, and we could also treat empirically. We need to treat with vancomycin to cover staph and strep, and ceftriaxone to cover gram-negative rot and gonococcal infection. Usually, imaging, it's not a diagnostic method, but pockets could help us to confirm any fluid in the joint, and we could also confirm the presence of myositis, or there might be some abscess in the area if the patient had a direct injection. It could be also valuable method in, for example, some small joints like wrist. And the way we are going to approach arthritis, it's doing the tap arthrocentesis. We are also sending blood culture, because I will tell you about the numbers later. And we are also sending mucosal swab from the mouth and genital area to ruling out a gonococcal disseminated infection, DGI. We learned that we do not exclude infection, even though, because the gram-negative sensitivity for septic arthritis, it is 50%, and there is a 20% positivity rate for bacteremia in any septic arthritis. And the synovial fluid culture has 70% positivity rate, and this number drops to 50% for gonococcal infection. We also develop a schema for culture-negative inflammatory arthritis. This has 3 buckets: culture-negative septic arthritis, crystalline disease with negative crystalline like CPPD. We are treating this category of the patient with anti-inflammatory, and we also need to look for any adjacent inflammatory effusion. Any osteomyelitis might trigger this situation. We'll need to look at the tibia, femoral. We need to look for any evidence of chondrocalcinosis on the X-ray, and we need to get an MRI of the knee and thigh. This is mainly common in the younger individuals, but we need to keep it in the back of our mind. To conclude the session, the final diagnosis was Cutibacterium acnes septic. Arthritis, we learned that it is a gram-positive rod living on the skin, and it is usually it's a really challenging situation to differentiate between, and it could be incidentoma and causing pathogenesis situation. Thank you, everyone.
Oh my gosh, Rachel, that was amazing. And I'm sorry there were so many difficult words like Cutibacterium and pathogenesis at the end of your breath there. That was amazing. Thank you, Julia, for scribing. Thank you, Anmol, for an amazing, amazing case discussion. To Parisa for teaching points, and of course to our guest Sadika for an absolutely incredible case. Really hope that we all get to see you. Happy Thanksgiving, everybody. Hope you have a wonderful day, and we'll see you next time. Bye.